Audible, sir?
Yes, yes.
So thank you, Satyavani, and thank you, Nitin, sir, and all the organizers. Actually, Dr. Assis and Dr. Shomik had made my life easier by sharing their knowledge. So now we are aware of the sarcopenia, and as the endocrinologist, we all are, and the physicians, we all are aware of the obesity also. So this entity is the sarcopenic obesity. It's the sarcopenia in obese individuals. So because sarcopenia is a new entity, and it like from 1980s, it it has now in 2021. So it got the ICD classification in 2016. So most of the physicians take its sarcopenia as that it's a problem of lean and thin individuals. It's not like that. It occurs in it's more problematic, and the life of quality is more affected in the obese patients with sarcopenia. So it's a increasing global public health concern, because it's the joint uh, of obesity epidemic and the population aging. So it's a combined clinical and functional entity, which is marked by the coexistence of surplus fat mass and the sarcopenia in an individual. So because in a for a uh, for daily routine of our life, we need muscle strength, and if our weight is more than our muscle strength, then our daily routine of life, quality of life, is affected. So it's a diagnosis of sarcopenia, and its definition is basically based on the sarcopenia and obesity. It's a combination of both. So there is uh, we have a definite definition of the obesity, but the definitions of the sarcopenia, as we have learned from the previous presentations, that it's largely heterogeneous, and the standardized definition of sarcopenic obesity is also lacking, and this is the major constraint in research and in advancing our knowledge in this field. So for obesity component, we all know that it can be addressed as oral or central adiposity. So for overall, we take BMI and the fat mass percentage, which is derived by the whole body DEXA and the BIA. And for if it's more than 32% in men and more than 40% in women. And the waist circumference we use for the central obesity adiposity, it's derived from the or it's the CT derived visceral fat mass. So it's if it's more than 90 centimeter in the men and more than 80 centimeter in women, and BMI more than 25 is the considered as the obesity. So for sarcopenia, there are these are the various guidelines and various cutoffs being used. Latest is the European Working Group sarcopenia on sarcopenia, which as discussed in the by Dr. Shomik sir. So hand grips less than 27 kg for male, and hand grip less than 16 kg for female, and gate speed is less than 0.8 meter per second, and the DEXA cutoffs are also as discussed by the Dr. Shomik also. So when we have diagnosed obesity and the sarcopenia, then we come up with the sarcopenic obesity diagnosis. So epidemiology is like prevalence of sarcopenic obesity varies between the depending on the population characteristics and the different definitions and different cutoffs. So considering all the studies, average prevalence in older adults is 5 to 10%, and it's similar in men and women, and it increases in more than 80 years of age. So in Indian scenario, if we talk about the as discussed by Dr. Somik also, the Chandigarh PJ Chandigarh study, the Sarcopubes in the urban settings, they use the BMI, waist circumference, fat percentage, fat mass percentage as the criteria for obesity, and the prevalence ranges from 5.4 to 6.3% in healthy Indian adult using the Asian cutoffs in more than 65 years. So as we can see from this table, prevalence of sarcopenic obesity based on BMI, based on waist circumference, and based on the fat mass percentage, it is it's between 4 to 3 only. So like we have discussed about the pathogenesis of sarcopenia and obesity, both are interlinked, and so decreased metabolic rate with the increasing age, and decreased physical activity, and decreased sex hormones levels, it leads to, and on the other hand, from obesity side, visceral fat accumulation, ectopic fat accumulation, insulin resistance, they led to pro-inflammatory cytokines increase, and the increase in leptin levels. So it leads to mitochondrial dysfunction, and oxidative stress is increased in the muscle, and the anabolic function of the insulin growth factor 1 is decreased. So it leads to catabolism of the muscle, which leads to sarcopenia. Similarly, in adipocyte hypertrophy and hyperplasia, leading to accumulation of the immune cells and the release of the pro-inflammatory cytokines, which leads to sarcopenic obesity. So, as I have earlier mentioned, that sarcopenic obesity is very detrimental for the elderly, and it leads to increased risk of fracture, increased risk of disability. It impairs their quality of life, and it increases the risk of cardiometabolic syndromes like insulin resistance, dyslipidemia, hypertension, and type 2 diabetes, and overall decreasing quality of life leads to depression, and the overall psychological health is compromised. And we have seen that sarcopenic obesity leads to poor outcomes in the cancer patients, and it increases the mortality risk. So we can see from this picture that sarcopenic obesity duo leads to dyslipidemia, type 2 diabetes, hypertension, frailty, and so sarcopenic obesity lead, and the cardiometabolic syndrome, if we can discuss the aging leading to aging with sarcopenia and abdominal obesity with cytokines, then the reduced physical activity. So we have already discussed these things, so we can skip this. So like therapeutic approaches, like Dr. Somik also discussed the vitamin D levels, with supplementation of vitamin D in the female especially, and because it improves the bone metabolism and bone strength, and likewise calcium is also included in the treatment, and major challenge is calorie restriction, and it leads to worsening of the sarcopenia if we are not supplementing it with high protein diet. So, and with the so uh, calorie restriction and the physical activity as the main cornerstone of the to counteract sarcopenic obesity. And the weight management is, like I said, it's very challenging for because it may exacerbate the sarcopenia. So combination of moderate weight loss diet with concurrent exercise and a high protein diet is required, which is distributed throughout the day. It's the most effective strategy to improve the body composition in sarcopenic obesity. So as we have discussed the calorie restriction, because to it leads to predominantly decreasing body fat, and it improves the physical function, and moderate energy deficit of 200 to 750 kilocalorie per day, with the target of approximate 10% weight loss in 6 months, and then the weight loss maintenance. Protein supplementation is required to mitigate the loss of skeletal muscle mass and the strength during the weight loss. Calcium supplementation is necessary to prevent impaired bone metabolism and during energy restrictions. So 1200 milligram per day is the dose. For likewise, vitamin D, the level should be more than 30 nanogram per ml. And the aerobic exercises, which to improve the cardiorespiratory fitness, 150 minutes per week, moderate to vigorous training. And the resistance training are the most important thing, which improve the skeletal mass and the strength, and they attenuate the muscle and bone loss during weight loss. So 60 to 75 minute per session, 3 non-consecutive sessions per week, with balance and flexibility and the strengthening exercises. So as discussed in the by the previous speakers also, the testosterone, myostatin inhibitors, mesenchymal stem cells, vitamin K, with anti-obesity medications, these are the under trial things, and we don't have definitive evidence till now. And as sarcopenia is a major debilitating disease, so there is a lot of research is going on the preventive strategies, because it's preventable, and we have to intervene, like we achieve the skeletal mass up to the age of 35 to 40 years. So we can intervene, like we have seen the last example who was 100 years old. So we have to intervene at the earlier age, because in the Sarcocube study we have seen that mean age was only 40, in the 40s and 50s only. So we can see that it's not a disease of like oldest old, or so we have to intervene in the middle age group. And the bariatric surgeries, and these are the unknown safety and efficacy, because especially in the elderly population. Neuromuscular activation has been also tried, like the vibrators, whole body vibration therapy using the electric stimuli. So, but there are no definite evidence that they improve the muscle strength and muscle mass. So, future is to establish a robust definition of the for sarcopenic obesity, so that we can diagnose it at primary level also by our ASHA worker or by primary healthcare workers, like they are diagnosing the malnutrition or obesity in the kids. It's being diagnosed and treated by at the primary level also. So we need to sensitize our physicians to so that they look for it. If they will know it, they can diagnose it. uh, we can we have to sensitize, we have to formulate a definition of sarcopenia and the cutoff, define the cutoffs, so that they can, it can be easily diagnosed at the community level also. And we need properly powered clinical trials for functional and disease specific outcomes. So to refine our understanding regarding the optimal dietary interventions, because just saying that take healthy diet is not enough. So we have to define the this healthy diet, and we have to be individualized according to our patients. If patient is vegetarian or non-vegetarian, so we have to consider all these factors. And to determine the optimal frequency and the intensity and the duration of aerobic and resistance training also. Because for while advising, we just say that do proper exercise, because so we have to make it a tailored therapy for our patients. Then only we can do better, and we can prevent the adverse outcomes of sarcopenic obesity. Thank you all for your patient listening.